it drop on repeat within a few months below 2.5. And if you use those age-specific thresholds I showed you before, the number is 30%. So up to a third of men with a PSA dropping to what you might consider normal. So we've got PSA and we've got prostate cancer now diagnosed. We're moving forward in the cascade to the world of over-diagnosis and over-treatment. The first table at the top is Andy Stevenson's data from 2009. And these were people who were treated and they looked only at their biopsy grade, not their final prostatectomy grade, looking at their cancer-specific mortality. And you see great news for those with a biopsy grade, never mind their final pathology, a biopsy grade of Gleason 6 or less, 2% 10-year prostate cancer-specific mortality. Sounds like something to celebrate. I think it seems awfully low, to be honest with you, if you're allowed to cheer for a cancer, which I'm not really, but you don't want to throw the baby with the bathwater. Similarly, if you're looking at people with Gleason 3 + 3 = 6 disease on their prostatectomy specimens, so you're not getting the upstaged people, or upgraded people, you're just getting the 3 + 3s on the specimen, the recurrence rates are extremely low. 15-year biochemical recurrence, never mind mortality, happening at 1.3%. This feels a bit like the analogy we always used to hear about appendixes. You have to take out a few normal appendixes to know that you're capturing the right ones. This almost feels like removing toes at age 1 so that you don't have the scourge of ingrown toenails and bunions later in life. All these Gleason 6 people, you're getting a signal that perhaps the intensity of treatment was a little bit more than they deserved or needed to have borne. Don't need to refresh too many on the anatomy, but of course you can divine a lot. And when you're talking to patients about their treatment, and when you're talking to junior learners about why it is such a big deal to go fussing around with the prostate surgically or with radiation, you come to realize that it's tucked oddly in the pelvis behind a big bone, that it's woven into the neck of the bladder and coated with a ghastly morass of blood vessels on the top, and vital nerves for erectile function tucked around and nearly invisible on the posterior. So it's a place that you wouldn't choose to go. It's not picking a ripe apple from a tree. It's buried right on the inside of a very important thing. And of course, you pee through it right in the middle. So we can think about it, or we can show specific data around it. And so we see, and this is from the Vanderbilt study of 2,500 men over 3 years, what happens to people when you ask them about their sexual function and their urinary incontinence after prostatectomy, radiation, or external beam or active surveillance in the green. And of course, no surprise to us, we see sexual function more of a drop in men treated than not, although there's a slight downward drift in the data. And then you see with urinary incontinence a drop in the surgical cohort. This is not the time for me to be too cheeky about it, but I've always felt that asking about incontinence seems to hamstring surgery as an obviously worse thing than radiation. I don't think any of us believes it. I think surgery and radiation are both good things, and there are both trade-offs to each that I just don't see reflected as much as I would expect in some of this functional data. But that's a discussion for another time. And if you want to see what happens when you exclude urinary incontinence from these analyses, check out Rob Nam from Sunnybrook in Toronto's study of several years ago at the population level for some insight. Population prostate cancer outcome study. This is Resnick and Penson, going out to 15 years. The data seemingly in the first few years are quite similar in the sexual function, a regression towards the mean. These are not parallel lines. Certainly it seems glib to tell people that you're going to lose your sexual function or urinary function eventually, and we're just front loading it with our treatment. But we do see that over 15 years, there is a bit of regression towards similar and decrease in function for just about everybody But it's safe to say that removing a prostate, radiating a prostate, is something that carries harms for people. And if they have disease that is only going to, as I'll go back for one sec, because I realize I was not showing you these slides as well as I should, that in recurrences for men with Gleason 3 + 3 = 6, low risk disease on their prostatectomy, less than 1% at 10 years, 1.3%. This is pretty undangerous disease, and these are results that ought to give us caution about the harms we may do. Here is me being cheeky about this. This is female urinary incontinence prevalence in women at 15 or more years from menopause, and the rates are as high as 60% prevalence for urinary incontinence. And I say this respectfully of this cohort. Of course, when I'm talking to men about their urinary incontinence risks after prostate surgery, I always note that there is a whole section at the drugstore for incontinence, that it is a thing in the population that is accepted, that is manageable. And that because it is an act of commission to do surgery, we tend to take it a little bit more aggressively. And so we've got some data finally to talk about our PSA screening. We're going to talk about 3 trials here: PLCO, ERSPC, and the Göteborg Trial, which is not ERSPC. About 10,000 of those Göteborg men were in the Swedish cohort of ERSPC. Another 10,000 were not. And from a recent lecture that I've come across, I've come to understand, but can't verify for you right now with a reference, that this was a slightly skewed younger cohort. So PLCO, 77,000 men. Think about this before you dive into these things. You know, what do you want from a study like this? Certainly lots of men, 77,000, 182,000, 20,000. Sounds like a reasonably good N. We've got a long lead time for prostate, so certainly we would probably ideally want to fast forward, you know, who knows, 20 years or more. Seems impractical, but that's where the data, I think, a priori might be most interesting to me. We have to think if we want disease specific or overall survival. Do the trials actually do what they said they were going to do? So everyone sort of should be familiar with these trials right now, but I'll run you through them very briefly. In this case, the PLCO trial, or the prostate part of PLCO, 70-odd thousand men who were treated with usual care or a PSA times 6. So this was not a lifetime commitment to PSA. It was 6 PSAs done annually, which seems like it's been part of our usual mode of care for annual examinations. They were intended to have a biopsy if their PSA was over 4 or if they had an abnormal rectal examination. They followed them up at a median of 11 years with a primary outcome of prostate cancer mortality, not overall prostate cancer mortality. They chose to see what PSA could do for prostate cancer and not necessarily as a standalone overall survival thing. And as you know, there was differences in the number of cancers identified. Now, of those 77,000, there were 500 more cancers identified in the screening arm, but there were 6 more deaths in the screening arm, 50 versus 44. Very small numbers in this case. The numbers are quoted, even though the follow-up was 11 years, the numbers are quoted as 7 years because that's where they had the vital statistics. You're getting this 11.5-year follow-up, which sounds better than 7 years, I suppose, but only 2/3 of the subjects actually had vital statistics available at that time. So the analysis really stops at 7 years. Remember your lead time. The bad news about this, of course, is that even though you said or intended for these men to have a biopsy over the PSA of 4, abnormal rectal examination, only 40% of the men did have a biopsy. The bigger problem, of course, is that usual care often meant prostate cancer screening or PSA testing. This was from 2016, Jim Hu and his team, showing that despite the fact that in the paper there was a 50% quote of contamination, 52%, that was a question that said, have you had a PSA drawn in the previous year? When they went and asked these people if they had a PSA drawn in the previous 3 years before their entry into the trial, that was 80%. 52% is bad enough contamination, 80% not great. And if they asked them if they'd ever had a PSA, at some point before they joined the study, another 10% added on. So you're looking at about 91% of men in the PLCO control arm who had a PSA test. So you're not testing PSA over PSA, you're testing or over nothing. You're testing opportunistic over systematic PSA. And so I think analyses and thinking and relying on PLCO is probably a bad idea. That's me being as aggressive as I can be. The RSPC trial, again, 200,000 or so men. They had PSAs about every 4 years versus an intention for no PSA, so not usual care. Their biopsy threshold was lower, and their follow-up was a bit shorter, published in the same edition of the New England Journal. Some countries had a threshold of 2.5, some as high as 4. And what you're seeing here is more identification of cancer. Still small numbers in these cases, but about double the numbers of cancers. This should say less PT3 and PT4 in the screening arm. The ones who did have prostate cancer had more, and a lower prostate cancer mortality. When they run these through, you get a number needed to screen of 1,140, and a number needed to diagnose of 48. That has been called number needed to treat. Remember the straw man at the start of the discussion. This is the number needed to diagnose. You do not have to cut 48 prostates or radiate 48 prostates. You have to diagnose them. More to come. They published that in 2009 with their 9 years of follow-up, and they published that in 2014 with longer follow-up, now 14 years. They published it again with an average of 16 years of follow-up, and you see what happens to that number needed to diagnose and number needed to invite to screening. I should also say that it's not number needed to screen, it's number needed to invite to screening. And suddenly you're down to a much more respectable 18 diagnoses, not all of which you need to be treated, not all of which you need to suffer harms for the identification or the life-saving from one. Now, of course, if you looked at these numbers and you stripped them of all their context and just said group A disease, disease Y, group A and group B, these would be sort of models of the use of absolutes versus relatives. So that 80 or 20% relative increase in survival ends up being very small numbers. And so this is where I don't think we need to trumpet wildly the unabashed success of PSA, but we have to keep the relative versus the absolute angle in mind. And so we've got 20% less prostate cancer mortality at 16 years. Remember, the follow-up is from the start of the study, not from the time their prostate cancer was diagnosed. And so in these cases, your follow-up from the prostate cancer diagnosis was only 4.5 years in the control, 6.5 in the PSA. So a slight enrichment for that group to do worse over time because they have an extra 2.1 years to die on this study, but you're still dealing with very short time frames. If you've ever run numbers through a nomogram about prostate cancer detection, you understand that just about everybody has a 98 or 99% 10-year prostate cancer specific survival with localized disease. 81% of the people were biopsied instead of 40, and the contamination was much lower. The PSA at entry of the Göteborg Trial, again, half patients, half not, and PSA every couple of years with a roving biopsy threshold, and 14 years of follow-up shows the best results of all. And I think one of the big things that I take out of this diagram here, we've all seen Kaplan-Meier curves in their and cumulative hazards in their various forms. One, the numbers are better here. But if you look at the number at risk, they're still quite high on the right side of this form, or the right side of this axis. And oftentimes when you're seeing the spread of the curves, it's when there's very few people left, and so you can't necessarily trust this information. There was less aggressive disease in the screening arm, found a little bit earlier, and there was a 0.56 instead of a 0.8 in the RSPC, a 44% reduction in prostate cancer specific mortality. And in this case, similar, a number needed to diagnose of 15, 18 we saw in ERSPC, and 234 invited to screening versus 500 and change from ERSPC. Why did it seem so better? Only 3% contamination in this case. They had lower PSA thresholds, so more people were getting biopsied and diagnosed. They were doing their PSAs not every 4 years, but every 2 years. And those who had an indication for biopsy received a biopsy and longer follow-up. Seems to be a more enriched thing. Some have pointed to the Finnish cohort as being the opposite and not doing as well. So again, I think we take all these things with as the data being sort of agnostic of our emotions around them. And what did we do with this? We got a D grade from the U.S. Preventive Service Task Force saying we recommend against PSA-based screening for prostate cancer. Cancer Care Ontario, a bright organization, saying we do not support organized population-based screening. And the Canadian task force followed in lockstep with the US PSTF, and they almost sarcastically broke it down by age groups before saying, we recommend for those under 55, not screening. For those between 55 and 69, not screening. For those over 70, not screening. That seemed like a little mud in the wound. And you've seen a few of these pithy diagrams which show you how a few people, that's the black dot in the right-hand column, will escape death from prostate cancer despite the harms. And this is from the numbers they've taken, including the PLCO trial. So what happened after this? What you would hope, I guess, was that the number of prostate cancer diagnoses ought to go down. Less PSA screening by the USPSTF in primary care, less prostate cancer. And as you see with colon as a control, there is less prostate cancer being diagnosed. Starting in October of 2011, you see a downward drift as there's less PSAs, less biopsies. But what you're losing as well is the high-risk ones. And so the low-risk diagnosis patients are the blue line going down, but the darker orange and the lighter orange lines are the intermediate and high-risk patients. Those are the ones you obviously would agree you still want to find, but their numbers are going down as well. Metastatic disease is rising in cohorts after this. This is from the National Cancer Database. Only 3% of men at diagnosis found to be metastatic, which seems a little bit low to me. But there you go. And beginning in 2008, which was the first USPSTF guidance against PSA in men over 75 with an indeterminate recommendation below 75, you're seeing a 9.3% annual change in that 2007 to 2013 era in the age 55 to 69 groups, new diagnoses of metastatic prostate cancer. And a more zen-like and calm curve from some SEER data from European Urology on 500,000 new prostate cancer diagnoses from 2018. I just like the sort of minimalist appearance of this, but it tells us the same stuff. And so the Canadian task force said, the only place that you can find any reference to something like surveillance, you can actually control F on these documents, and you won't find the word surveillance. But the only sort of hedge there was that altering these thresholds or intervals, uncoupling screening from treatment, can favorably change your risk-to-benefit ratio. But they did not take active surveillance into account whatsoever. I'm going to use the Sunnybrook cohort here because it's close to our Canadian hearts, but any of these cohorts will show you similar things, especially if they include a little bit of intermediate risk disease. But in the Sunnybrook 1,000 patient active surveillance cohort, you've got 98% cancer survival at 10 years. You've got 94 at 15% or at 15 years. The majority of these men, and by that I mean about 3/4, had Gleason 3 + 3 = 6 or grade group 1 disease, but 1/4 of them had pattern 7 disease, generally low volume. In this cohort, 15 men overall had died of prostate cancer, 13 additional men at this time frame. And in this case, you see the number at risk is quite low on the right side of the axis. Those are the people who are in trouble or dead from their prostate cancer, and the vast majority of them were in the intermediate risk cohort. Those patients with Gleason 6 disease, which make up a large group of who we diagnose, do not, in fact, need upfront treatment, should not count against the harms of treatment. In the intermediate risk disease, of course, this paper says to us and informs me to tell these men, I will support your decision for active surveillance, but I won't specifically recommend it in these cases because the results were inferior in the small intermediate risk group of 213 men. But when you look at the actual numbers and say, well, what are the odds I'm going to be alive in 15 years? It's still 9 out of 10. It's still 82% free of metastases in that group. And so if you spin the data around that way for patients, they may still make the decision around surveillance. This is not a message in pro-surveillance other than to say that the SBCG4, much vaunted 4 times published New England data, still took 10 years for the curves between observation, which is not active surveillance, and radical prostatectomy to split. And so in the early going, there certainly seems to be a reasonable approach to observation for well-chosen men. These men were sicker than what we're seeing in our current active surveillance cohort. Pivot trial then checked observation versus radical prostatectomy, and in the overall group did not find a meaningful difference between the two at 10 years in overall survival and prostate cancer related deaths. But for the intermediate risk cohort, there was smaller numbers, but a significant, if you're at the altar of P equals 0.05, significant difference in survival. So for the low risk groups, it still seems that there's a reason not to treat and that these ought not to be counted as harms. And more recently, the PROTECT trial showing the active monitoring group, a fair number of which ended up with some form of treatment. 77% of these people were low risk, and you're still seeing excellent outcomes for prostate cancer specific survival. Another delightful Kaplan-Meier curve because we never see things so squished up here. You almost want a Fox News style y-axis so you can see some separation. Start it at 90 and see what we get. You do see on these data, however, that there's a difference in the metastasis and progression on the surveillance cohorts. So again, in some groups, you are seeing people in a little bit more peril, but for the most part, these curves, at least in the survival angle, are like DNA overlapping each other almost completely, giving credence to the fact that not everyone with an identified cancer needs treatment. Do we do it? This is not a time-based series here. These are actually centers in Quebec, Ontario, Manitoba, and British Columbia, and their uptake of active surveillance. Canada has always been strongly uptaken, but 77%, these data are accrued from 2010, so this is a good long time ago. These numbers are probably even higher for low-risk disease right now. Surveillance is happening despite the USPSTF not acknowledging its existence. So the USPSTF, after all of this, changed their or walked back their recommendation from a D to a C. For Canadians, this didn't seem like a hugely dramatic thing, and I would seek clarification from my American colleagues, but my impression is that a B or an A recommendation equals mandatory funding, and so they're a different sort of beast rather than a linear progression from A through D or D up through A. The C means that you can share your decision and talk about it, but does not mandate payment by CMS. I may be talking in my ear. Another angle on the PSA is when we're talking about screening or PSAs is not the classic screening, not the classic case finding, but getting a baseline number and using that to decrease the frequency or amount of PSA burden so that we're not overdiagnosing. And a lot of this comes, in this case, is from the PLCO trial, reanalyzed from Stacy Loeb and David Crawford in a couple of papers showing that for those people in the PLCO who had a very modest median PSA, if their initial PSA was in the 1 to 2 or 2 to 3 range in this group, that their, 1 to 2 range, that their PSA progression to what we would have considered abnormal and encroaching on our biopsy recommendation threshold is actually quite low, 1.5% and 7.5%, and that those men with PSAs less than the median represented only a small fraction of those people ultimately diagnosed with advanced cancers. Mark Preston, in the last several years, and his team at Brigham and Women's proud Canadian of South African descent, has published on these single values for lethal prostate cancer. And this is in all comers in the Physicians' Health Survey. So these were men ages 40 to 59, 22,000 of them. They were doctors filling out surveys. They found 234 with prostate cancer and 700 odd matched controls. And you can see the median PSAs here, 0.68 for the 40 to 49 group, all the way up to just shy of 1 for the 55 to 59 group. And of those men whose baseline first PSA in their younger middle age, quote unquote, based on those age groups, had a supra-median PSA, they had an odds ratio of anywhere between 2 and 4 of being diagnosed with a lethal prostate cancer. And so we're seeing that if those men, half of them by definition, with PSAs less than the median, perhaps can be less rigorously followed because overdiagnosis becomes a problem, and their likelihood of a lethal cancer over this long study is low. If you use the 90th percentile, these are numbers that still often don't make the threshold of referral. So this is sort of a thing that really is probably more germane to our primary care colleagues. But the 90th percentile PSA for a 49-year-old is 1.6. That's not particularly high. And even for a man in his late 50s, it's just shy of 3. But you can see the significant enrichment in lethal prostate cancers, anywhere from 7 to 12.5 times in the odds ratio if you're using that as a threshold. So those are the people you want to watch closely because missing out on them is missing out on an opportunity to find the balance of those who are dying. For men of African descent, the numbers go completely wild here. Now, I want to say that this is aggressive prostate cancer, which is defined as death, or pattern 7 disease, which are very different things, or stage 3 to 4. So this is not the same as the lethal comparison. Same group, same appearing slide. But the median PSAs are surprisingly quite similar in the African American men versus the all-comers previously in the physician health study. The 90th percentiles are slightly higher, but you're seeing that an aggressive prostate cancer in an African American man between 40 and 54, the PSA over 1.85 enriches for 174. There's no missing decimal there. Odds ratio of aggressive prostate cancer, and 52% in the older age groups. ERSPC trial as well, showing that the majority of the people doing poorly had their first PSA as the abnormal one. So it's not really those PSAs that we're sort of tracking over time. It's the people when they rolled up, said, thanks for handing me to this trial. Here's my blood. PSA is abnormal. Those people were an enriched group for worse outcomes as well. So it tends not to be so much in the following, although, of course, you're seeing there as well. Almost finally, the PCPT risk calculator. I think, I oftentimes find myself nearly apologizing for being seeming patronizing around the use of smiley face histograms, but there's a reasonably robust data around the use of these things as good for patient information. I find these because this is the essence of shared decision making. This is when you look someone in the eyes. Remember when they tell you when you're examining someone's belly for an acute abdomen, look them in the eyes to see if they wince. In this case, you fire up these numbers, you press the button, and fields of green, yellow, and red show up on the screen. And you can see, and you can ask the patient about their gut reaction to this. I may see in this hypothetical 65-year-old with a PSA of 7.1, no family history, negative rectal examination, no biopsy. I may see 9%, and I may feel a bit relieved, depending on how sick, obese, etc. the patient is. I may feel relieved that this didn't seem so bad. The patient may look at that and say, you're telling me I got a 1 out of 11 chance of having an aggressive cancer? Man, oh man. That's the essence, or at least the most crystalline version of shared decision-making that I can think of. And just because I promised this for the free to total ratio, I feel like this must be some statistical wobble, and maybe they didn't have all these free to total ratios quite available to them, or maybe it is the truth about the power of the free to total PSA. But when you're seeing this, again, hypothetical age 65, PSA 7.1, negative rectal examination, and a free to total ratio of 25%. That's pretty reassuring to me most of the time, especially when I log the guys with the thermometers in there who should be frowning, that 3 to 4% who get sick. And when I switch this free to total ratio to 7%, the entire field goes wild. And that may speak strongly to the importance of the free to total ratio for these men between 4 and 8, but certainly from a shared decision model, if somebody is fixated on their number as being not terribly impressive to them, their free to total ratio that they may not have concerned or considered certainly may paint a bit of a different picture and lead them towards that. What do the guidelines say? Finally, the AUA guideline updated in 2018 from the 2013 guideline speaks of the shared decision for men starting at age 55, ending at age 69. These are guidelines, and we are clinicians. We're allowed to do this in men in age 54 and 71. A 71-year-old now is not the same as a 71-year-old from whence the data was originally garnered in the 90s, 80s, and 2000s. They talk about some subsequent approaches here, which are often quite different than our Canadian system. This is the use of adjunctive measures like 4K, PCA3, and the myriad racing and scrambling genomic tests, and that you, quote unquote, may spread the interval out a little bit. Our Canadian Urologic Association guideline, for my American friends, go to CUA.org. It's actually a very nicely written, short guideline. It doesn't say anything that's going to surprise you, but I think it's a nice, concise, and easily readable, digestible piece. It says much of the same thing, but drops the age of shared decision making to 50, speaks to the potential importance of the free to total ratio, and actually gives you a bit of a map for the spreading of these things. So they're not using medians here, they're using numbers. So if your shared decision making means that you've got a PSA that's less than 1, you're going to help avoid over detection and wobble of that PSA by repeating it, say, every 4 years. If it's over 3, you may want to get out down to your every 1 year. And there's the adjunctive strategies as well, risk calculators, free PSA, for example, and then discuss around the role of a biopsy. Prostate cancer kills men. I hear patients say it. I say it. I hear everyone say it. Men will die of or with prostate cancer and not of it. It is true for those for whom it is true. It is extremely untrue and very unhelpful for the 10% of cancer deaths that are prostate cancer. Some of these men will not die if they get screened. I think that's quite reasonable. Some of them may. There are D-type tumors out there, and there are ones in whom we cannot control even with our interventions. PSA is not going anywhere, and the straw man that says that the PSA test edifice is the same as square brackets, indiscriminate population level screening for all men. That conflation or straw man is unhelpful. PSA is important to us. Smart use of PSA and its adjuncts in the case finding and screening can be helpful. Of course, in the treated population and in those with very low and extremely high PSAs, we get a lot of information about it. Overdiagnosis of those grade group 1 is a real problem, but an overtreatment of those, if we choose to, is a real issue. But active surveillance is also a real issue with real uptake and ought to be factored into these equations. Number needed to diagnose is not the same as number needed to treat. I appreciate your time and I appreciate the invitation, and I suppose I shall field some questions if there are them. My general line is that I've put all my eggs on the field giving these. So thank you for your attention.
Thank you, Dr. Leveridge. We've got a couple of questions from the audience. There was a couple earlier. Dr. Siemens may have answered a couple of them. One was, there's an argument that the New England Journal of Medicine graph only represents metastatic disease at diagnosis, doesn't represent true prevalence of metastatic disease. And you did go through a lot of this data, but I guess the bulk of this question is there any good or better source for the true prevalence of metastatic disease?
I suppose it's difficult with coding, of course, is when you're talking about the large databases, they seem, and it's both the NCDB and SEER, looking back on the incidents, they seem both to identify around 3%. And I said that seems odd to me just because anecdotally, in a town like mine, with our catchment area of about 500,000 for advanced prostate cancer care, boy, do we see more than 15 of these men a year coming in. And so the numbers just sort of seemed odd, but are similar to each other. So unless there is a similar acquisition and coding problem in those two databases, then I think the data are clear, and that may be where the real information is.
There was another question when you were talking about the repeat use of the PSA for patients with abnormals. I think the question is basically asking, is the first PSA true, or is the repeat PSA true, or how much do you trust repeat PSA?
I'm a believer in repeat PSA. I would say that, one of the classic questions is, why did my PSA go down? And my very unhelpful answer is, whatever the opposite of what made it go up is what happened. And I usually think that the lower PSA is probably a more appropriate reflection. Cancer won't go away, and if the PSA is being driven by a cancer, then that should not wax and wane. Whereas an inflammatory cause, which is my very blanket term for anything that's not inexorable BPH or cancer growth, that seems to be something that ought to wax and wane. And I've come up with a million things that satisfy the sort of existential hole about why this is happening. Why does this man have a PSA of 12 and a small prostate, and I've biopsied him 4 times and MRI'd him and negative, and I say inflammation to myself, and I say urine rattling around inside the ductwork, and I say AVMs and things like that to myself to soothe. I don't really have a reason, but certainly it seems to me that BPH is a progressive thing. The cell number rises, and cancer grows or stays stable, depending on its grade group. And so the falling should be a regression to the truth rather than a false negative.
Question regarding PSA and the MRI. How do you think that the utilization of MRI changes the equation?
Utilization, it's a good question to potentially separate out how we're going to act maybe in USA versus Canada. And I think right now Europe versus the United States, the AUA has come up with some guidance around the role of MRI, whereas the UK and the European guidelines are recommending it for abnormal PSAs. Now they are basically saying do them in front of biopsies rather than use them instead of PSA. I don't think there's any body that would suggest not having PSA as an adjunct or a precursor of MRI. I have a worry around MRI more related to biopsy than to PSA, in that, of course, it is easier to fill out a requisition than it is to obtain consent. It is less aggressive feeling to put someone through an MRI than it is to impose a biopsy on them and all the trappings and risks associated with it. And so I think it requires some thought around the appropriateness of MRI versus biopsy. I think the mindset has to be, I would biopsy this person, but I'm going to MRI them because I believe in the data from Precision and Promise and MRI First, and I want it to enrich my biopsy or potentially obviate the biopsy in this case. But it ought to be a person you would be considering for biopsy. Your threshold can't be lower. I suppose if everyone's willing to fork over for it, but in a system with any kind of public funding, instant overwhelm. Our MRIs are not terribly expensive here, but would be rapidly filled with an endless chute of men going through them if we if we changed our thresholds.
2 more questions. How would you handle PSAs between 4 and 10 with benign DRE in a population of African men with routine prostate sizes greater than 100 grams without prior PSA trends? So the question here is saying, what is the role of PSA density, free and total PSA, MRI, etc.? How much does size matter?
I feel like size matters a lot insofar as I think your MRI threshold might be you know, now that I've stick my foot in my mouth, maybe it's a slightly lower per PSA if you're expecting a very large gland, because there is in my mind a role for at least the potential to enrich the biopsy in the setting of a positive MRI, giving some target. I think a huge part of helping or abrogating the problem we may see in the disparities in the African American men is, of course, part of it is potentially is a disease biological thing. But just getting entered into a screening protocol and having someone watch you is an advantage that is offered at a different rate in the African American population than the non-African American population. So they've already done well by being in a benign setting in a screening population. So once in, I would have perhaps a slightly lower threshold, thinking about those 90th percentiles and above median PSAs, but I do keep the density in mind.
Then, are you presently using the free and total ratio for repeat or initial testing?
I love free to total PSA, and I believe it when the PSA is 3, and I believe it because when the PSA is 11, because the 4 and 10 were human choices, and I don't see a biological rationale. So maybe I'm doing a little confirmation bias when I'm trying to augment my decision making or my communication with the patient, but. Oftentimes I can't use it at the initial PSA because I didn't order almost ever the initial PSA. And if it's done, it's done. And unfortunately, we can't go back. But I will use it very frequently on my repeats. That's sort of almost reflexively for my PSAs between 4 and 10.
Great. Thank you very much, sir.
My pleasure. Thanks so much. I really appreciate your help. Getting things set up at the start, and to the whole Albany team and the whole upstate New York team. It's been a fruitful relationship that we really enjoy up here at Queens, and we look forward to seeing you all again next year. I will be on these meetings again.
Thank you, Mike.
Thank you.
All right, guys. Thanks, everybody.